Michael showed some slides, payment for performance. I personally have a real problem with the term payment for performance because it implies that the metrics that you're using are actually measuring somebody's performance. Right? I mean, that's what it says. Now, if I look at hemoglobin A1C rates, screening rates in diabetics, what I'm looking at is a metric of hemoglobin A1C rate scores in diabetics. I'm not measuring anybody's performance necessarily. If I say I'm measuring performance, I'm making an inference that that metric is related to the performance of that thing I'm looking at. So anyways, I have a problem with the terminology, and it mixes up cause and effect, just like that. So this is a study from JAMA last year showing an improvement in the rate, these are cardiac-related, cardiovascular-related metrics that these physicians were paid for. And before the thing started, 87% of the physicians were compliant with these measures, and afterwards, 94% were compliant. Payment for performance works. I mean, that's the conclusion. Except, and very importantly, they had a reference group of physicians that weren't paid for performance. And their rates, basically the same. That they also went up. I mean, this was stunning to some of the people in the payment for performance world because they have been looking at study after study after study. The preponderance of evidence shows the payment for performance worked because they only looked at the left side. They didn't have the right side. So the question, you've got to know what would have happened in the absence of your program or your quality of care initiative or your policy or whatever is going on. And the real challenge here is setting up a situation where you're looking at these C's, these confounding metrics. Whoops. This is an article that appeared in the American Journal of Managed Care last fall. The title is Evidence for Defective Disease Management is $1 billion a year a good investment. And they reviewed some articles and they concluded, well, it appears that disease management improves quality of care, but the evidence regarding financial impact is insufficient. But the important thing about the article is what their final concluding statement was, it's as if we wrote it ourselves. Payers and policymakers, you notice they don't say physicians. I find this interesting. I think doctors and physicians get sort of left out of things in many cases. But anyways, payers and policymakers should remain skeptical about vendor claims and should demand supporting evidence based on transparent and scientifically sound methods. So as Joel said at the beginning here, our big push initially is show your work. Be transparent about the methods you're using to make your claims. Trust but verify, etc. So our whole effort here is founded on this. Our institute was founded 3 years ago. It's a 501c3 nonprofit organization. As Joel said, we're here to promote credible, transparent, and replicable evaluations of defined population health programs. We've got some interesting supporters out there in the world. This is from a business organization called Institute for Health and Productivity Management, who adopted these ideas. The second one is important. How do you determine value of a program? Because, of course, employers have wellness programs, disease management programs, payment for performance programs, et cetera, fitness centers. Transparency of methods and measures. Replicable, valid, credible. So we think that's very important. And from the clinical side, Case Management Society of America, same thing. They believe that the evaluation standards to determine if case management or disease management or physician medical management works or not should be scientifically credible, transparent, and replicable. This is just a list of the committee members, and there's several of them are here in the room. In fact, I was thinking, Michael, we have Michael Millicent, my keynote speaker. Later this afternoon, we have Mary Madison and Martin McDowell. We have 3 people with the same initials. I don't know what that means, but But we have people, and those of Martin McDowell and Mary Madison will talk about the committee structure and the wide range of input we're getting from lots of different kinds of people. This is one of my favorite slides. I actually paid for the right to use this slide if I even go ahead. But it's a Sidney Harris cartoon, two mathematicians standing at the blackboard with some fancy equations. And in the middle it says, and many of you probably sympathize with this if you ever took math. We all did take math. In the middle, and then a miracle occurs, right? And the guy says, I think you should be more explicit here in step 2. Well, what you see in many places in our healthcare system, certainly outside of the standard patient-physician relationship, is a lot of miracle methodologies. Or at least they're said to be miracles. We don't know what they are. They're not disclosed. And it's our belief that you make a proprietary process, proprietary drug, we don't really care how you made that, or that some people may. What we're interested in is you're making a claim that it does something. What is the methodology you're using to make that claim? We don't care what it is. If you go before, you had your program, and let's find people with 3 or more visits and see how many of them have 3 or more visits the next year. And it's a nice comparable reference. And guess what the answer was? Exactly the same. And they're like, it's a destroyer of worlds. It really is. And they didn't know what to do with it. And they didn't know who to blame for it either, except me. Well, before you came along, everything was fine. So that's why I became a consultant. Anyways, so what you need is to know what happens in the absence of that, and you basically need a comparison, a reference, what we call reference. And ideally, you have in that reference, you have a baseline, you have a follow-up, and what that reference is doing is ideally telling you what happens anyways. And then now you have your major comparisons, the post-comparison in your intervention group versus the post-comparison in your reference group. But that's not enough. You've got to, first of all, know that the 2 groups were equivalent at the beginning, or as close as possible. So you want to compare A and C and so forth. So that's sort of the big framework. And Gary Carneal, who's one of the co-chairs of our conference, has agreed to help us organize an accreditation program to put this into practice and get it out there in the marketplace. And in this accreditation, and I'll walk through some of the standards at some time, but essentially we have 4 components of this methods evaluation process program. Operations, what we're saying, like in an accreditation program, we say, is the organization committed to such a thing, to a quality evaluation? So yeah, we want some. If you don't want just somebody like me hanging around doing stuff, you want the organization to say, yes, we want that to be done. Because they can get rid of people like me pretty easily. The second part is the setup. Basically setting up your program or your policy or your quality process where it is ready to be evaluated. You identify the pathway, you define the metrics you're using, including confounding variable metrics, you select your referent, and so forth. And we'll talk about the referent. That's one of the most complicated things we found out what we've got going here. Then the third part is the baseline. You say, well, we have our metrics defined. Let's put values onto our metrics, numerators, denominators, and so forth. It's pretty simple stuff, really. And all we're asking for is one type 1 metric, one type 2, one type 3, and one type 4. And it's sort of laying out a framework which can be built upon in the future by essentially adding more metrics and taking them into account. And the last part is the follow-up after you, and this is where most people start, by the way, the follow-up. Right? Hey Tom, we've done this program for 5 years, we want to know if it works or not. And I said, what did you do these 3? They don't even know what I'm talking about. They just magically want to see if it works. So the follow-up is essentially doing the same thing you did at the baseline, except you put the values of the metrics after the intervention and compare them to the referent and get a sense of what happened to them. if something happens.